Chairpersons, please honor our speaker. I would request Dr. Sandeep Gupta to please facilitate our chairpersons with a memento. Now I invite Dr. Ashok Singh, who will detail us about biologicals in bronchial asthma.
And now I would like to call Dr. Ashok Singh, please deliver your lecture on today's topic, biologics in bronchial asthma. Please, Dr. Ashok Singh, please proceed.
So very good morning all. I would like to thank you first the JAMSCON organizer who has given me opportunity to be part of this CME. So रात गई बात गई सुबह हो गई. We should have been in the class early in the morning, but it is very discouraging to see that such a low audience here with us. I brought a topic which is new in bronchial asthma, which is coming up from the world, and I just wanted to tell about what are the new things which are coming in the bronchial asthma. So let us talk about the problem. The bronchial asthma is a heterogeneous disease. The problem of bronchial asthma in India is almost 1.31 billion people of India, 6% of children and 2% of adults are having asthma. It has been estimated that approx 140 billion Indian rupees are wasted in the treatment of asthma in a year. These are all quoted from some studies. The biologicals which are approved in bronchial asthma worldwide is omalizumab, mepolizumab, racilizumab, benralizumab, dupilumab and tezepelumab. But in India we have only three, that is omalizumab, mepolizumab and benralizumab. Omalizumab is anti-IgE antibody which block the receptor on eosinophil on which it comes to act. Mepolizumab is antibody against an interleukin, that is interleukin 5, and benralizumab is the same type of molecule which is act as anti-IgE, anti-IL-5 antibody. So the question arises, should we give these biologicals to all bronchial asthma patients? The answer is no, we should not give these biologicals to all bronchial asthma patients. So to whom we should give this then? There is a clear-cut definition in which these molecules can be used. There is two distinct terms nowadays which has to be understood clearly. There are two types of words running around the world, that is difficult to treat asthma and severe asthma. Difficult to treat asthma can be managed with optimizing the treatment. But severe asthma is those which do not, we have to understand, which do not get control with high dose of inhaled corticosteroid. What is high dose of inhaled corticosteroids? Let's have a look on severe asthma definition first. Asthma which require high dose of inhaled corticosteroid and long-acting beta-2 agonist molecule or leukotrienes modifier or theophylline in most of the days of previous year, or who require oral corticosteroid for more than 50% of the times in the last year, to prevent it from becoming uncontrolled. So here there are two important terms, high dose ICS, inhaled corticosteroid, and uncontrolled. What is the meaning of this? Let's have a look on that. This is high dose corticosteroid. The beclomethasone, budesonide, cyclosinide, any patient who is requiring more than this dose of inhaled corticosteroid in most of the time of the whole year, those patients are considered to be a severe asthma case. So any patient who is having requirement of inhaled corticosteroid more than this dose, there are two standard body. One is ERS and ATS, European Respiratory Society and American Thoracic Society, and GINA, a global initiative against asthma. So they said there are different high dose, their definition is different for high dose inhaled corticosteroid. GINA says that 1000 of beclomethasone will be considered high dose, whereas ERS and ATS says that 2000 is the cutoff point. So we should understand our own level. According to me, this ERS ATS is more correct. So let us now understand what is uncontrolled asthma. Those who are, this is the definition by which we can say that our bronchial asthma patient is controlled or uncontrolled. We have to see the 4-week history of the patient. These 4 symptoms, first, second, third and fourth, these 4 symptoms we have to ask whether the daytime asthma symptom is present more than twice in a week, whether there is any night awakening, does the patient require reliever medication in last week more than twice a week, or is there any limitation of activity, patient is not going to work or do his job, student is not coming to the class. So if there is limitation in the activity, that is also a symptom. So if there is no symptom in the last 4 weeks, then it is called well controlled bronchial asthma. If there is 1 or 2 symptoms, it is called partially controlled bronchial asthma. If it is more than 2, means 3 or 4 symptoms are there to the patient, it is called uncontrolled bronchial asthma. So any patient, now coming to the same slide, what is severe asthma? I have to understand, you have to understand, everyone has to understand. The severe asthma is those who require more than high dose of steroid in most of the days of previous year, or oral corticosteroid for the most of the days of the previous year, to prevent it from becoming the uncontrolled. Now what the GINA says? GINA says we should give the treatment of bronchial asthma patient, low dose inhaled corticosteroid should be started, and that can be, the dose can be increased to the stage 4 up to the medium. And if any patient is in stage 5 treatment, means high dose of steroid is required, inhaled corticosteroid is required, then it is stage 5. If your patient is on stage 5, then your patient is a severe asthma case, and it has been seen in the studies that if any patient is on the severe asthma in a high dose of steroid and we give biological to them, their steroid dose is minimized, their frequency of exacerbation is minimized, and it is having the good benefit financially as well as working condition of the patient. This is the stage on which biologicals has been prescribed in GINA. And this I have already explained to you. Now come to understand the difference of severe asthma and difficult to treat asthma. If any patient is having these symptoms of bronchial asthma, what are that? Cough, wheeze, chest tightness. If these symptoms are there, even if giving the inhaled corticosteroids, then we have to assess whether the diagnosis is correct or not, whether the other comorbid conditions of related to bronchial asthma is controlled with the proper medication or not. So, the diagnosis in diagnosis, you have to review the diagnosis whether the patient is actually having bronchial asthma or not. So, what are the diseases which mimic the bronchial asthma? That is vocal cord disease, gastroesophageal reflux diseases, anxiety, obstructive sleep apnea, COPD, bronchiectasis, heart failure. These are the diseases which may mimic like bronchial asthma. If these diseases are there, then there is a different treatment for this. If any patient is having the symptom actually of bronchial asthma, you have made the diagnosis with proper spirometry that this patient is only and only bronchial asthma, then in these bronchial asthma patient you have to see whether they are having presence of symptom, and then you have to check whether he is taking the medications properly or not. If he is taking the medication properly, there is adherence in inhalation. You have to check the technique of inhalation also. If there is good technique, even then his or her bronchial asthma is not controlled, then we will have to think of that this is actually the severe bronchial asthma patient. In that, we have to start the biologicals. In these patients, we can ask for a fractionated nitric oxide, which is a good marker of inflammation in the airways, and these fractionated nitric oxide may be helpful in the making the diagnosis. Once you have made that your patient is having severe bronchial asthma, then you will have to go for phenotyping of this bronchial asthma. As for the data available of all bronchial asthma patients, only 24 is having difficult to treat asthma or severe asthma. In all these difficult to treat asthma, only 17% is having actually difficult to treat asthma. If you optimize the treatment, these patients may get corrected. After optimizing the treatment, even then your patient is having problem, it means that is the severe bronchial asthma actual. And for these patients we require to check whether there is good adherence to the treatment or not, whether there is good inhalation technique or not. If these things are there and patient is having still problem, then we have to think of about the biologicals. So, how to optimize the treatment, how to evaluate the difficult to treat asthma patient for biologicals. First, you see whether your patient is having problem even after giving the high dose of steroid, that are called the difficult to treat asthma. If there is uncontrolled in the bronchial asthma symptoms, then you will have to see whether there is any contributing factor. Then you will have to see there is any contributing factor for symptom not to control. If there is some contributing factor like presence of allergen, obesity, sleep apnea, anxiety, if these contributing factors are there, then you should try to optimize those factors, treat those factors. And if after that also your patient is having problem, then you have to see you have to give the treatment of high dose steroid for longer duration of time. If high dose inhaled corticosteroid are given for 3 to 6 months and your patient is having problem still, then you should think of giving the biologicals, and these biologicals are to be given according to the phenotypes. So there are two major phenotypes. In this I have given so many: aspirin sensitive bronchial asthma, allergic bronchopulmonary mycosis, severe or late onset hypereosinophilic asthma, allergic asthma, non-eosinophilic asthma. In this there are so many. So majorly if we see there are two main types, allergic predominant asthma and eosinophilic asthma. In allergic predominance there is high IgE level, high FeNO also, but in case of eosinophilic asthma this FeNO will be very high, IgE will not be that high. So in this way we can do the phenotyping of these patients, and after phenotyping we can give biologicals. For different phenotype there is a different biologicals. If total Ig is more than this, total Ig, blood eosinophil count, sputum eosinophil count, FeNO, these are the markers of severe asthma. In one study it has been seen that FeNO and eosinophil count is directly proportional to rate of exacerbation. If FeNO is high, eosinophil count is high, the exacerbations will be more to the patient. In such patients we have to think of about the biologicals. This is the mechanism by which you can understand where these molecules are working. Mepolizumab used here, IL-5. Benralizumab is work on the receptor of interleukin 5 on eosinophil counts. Whatever the allergens or pollution causes damage to the epitheliums, they releases various cytokines, and these cytokines activates the Th2 cells. These Th2 cells gives many interleukins, and they give rise, they activate the B cells and IgE is produced. Here the emalizumab comes to work and give benefit to the patient. This is the mechanism of action of mepolizumab and benralizumab. You can see benralizumab actively kills the eosinophils, whereas mepolizumab is passive eosinophilic apoptosis. It is been caused by mepolizumab. Yeah. Now I am coming to see what are the side effects of taking the oral corticosteroid. We all know that it may cause various problems. So to avoid the corticosteroid, we have to use the biologicals. The dose of biologicals in India, there are 3 biologicals: omalizumab, mepolizumab and benralizumab. Omalizumab has to be given in dose of 75 to 375 depending on weight and IgE level of the patient. The frequency of giving this is 2 to 4 weeks. Every 2 to 4 weeks Mepolizumab has to be given every 4 weeks, and benralizumab for the first 3 months we have to give every 4 weeks, and after 3 months we have to give every 8 weeks. This is the dosing of omalizumab if there is weight band of 30 to 60, 60 to 70, IgE level 30 to 100, like this. If according to weight and IgE level we can give omalizumab every 4 weeks or every 2 weeks. This is the dosing. Benralizumab, as I already told you, the first 3 months we have to give every 4 weeks, and after 3 months we can give every 8 weeks, means every 2 months we have to give 1 injection of benralizumab. These are the molecules I already told you, and in various studies it has been seen that they are very safe in use and they are efficacious. The adverse effects are very minimal in these biologicals. So the question arises, is there any overlap of the symptom, overlap of the phenotypes? Yes, some of the patients who are eligible for omalizumab are also eligible for mepolizumab. It means they have both IgE level raised and eosinophil count raised. In one study it has been seen that those who are eligible for omalizumab are eligible for mepolizumab also, and those who are eligible for mepolizumab are eligible for omalizumab also. In few cases this can be seen. This is the all mechanism of action and effect of these biologicals, and this is the new molecules which are now about to be coming up, that is TSLV, anti-TSLV, that is tezepelumab, which is thymic stromal lymphopoietin antibodies. This is new molecule which is about to come. That's all. Thank you.
Thank you, Ashok, for such a nice and informative lecture. I would like to ask one question.
Yeah, sure.
In certain cases, when there is a bronchial asthma and COPD overlap syndrome,
Yeah.
what is the role of biological in such cases?
Actually, I already told in my lecture that if there is doubt about the diagnosis, if there is overlap, you are yourself understanding that the patient is having overlap of COPD. So it is better to correct the COPD first. If after COPD treatment your patient is not controlled with, then we can think of about asthma, and then biologicals can be used to manage their asthma part separately. Yeah. Even after giving the COPD treatment, your patient is not having good control of symptom, then we can think of about other part of the asthma. Experience about biologicals, I will say omalizumab is very good. If any patient is having more than 500 total IgE level, it is been seen that it is very much good in controlling the exacerbations.
After few course of time, can we stop the steroid?
Yeah. After?
Few course of time when we have started the biological?
Yeah, we can stop it after 1 year if your patient is having good control of symptom.
How long we can use this biological?
1 year to 2 years maximum. Yeah.
What after that?
After that, you have to keep the patient in follow-up. If your patient is having good control, I have the patient in which I have used the biologicals, omalizumab especially, and the patient has not came back that I am again exacerbating my symptoms regularly.
Is there any side effect of these biologicals?
Side effect of omalizumab as such is not very high. Only thing is anaphylaxis. So the first 2 or 3 doses you have to give by in observation, and after that patient can take at home also.
Okay, thank you, Dr. Ashok. Is there any other question?
From the audience side? Okay.
Okay, thank you.
Okay, fine, fine.
Thank you.
Dr. Vinod was willing to know the cost of biological.
Yes, yes, yes. This is very important and very genuine question. The cost of biological is very high. Omalizumab is coming in about 20 to 25,000 one dose. Yeah. And mepolizumab is much more costly. Benralizumab is more than that, but the dosing is less, so overall cost of mepoli and benralizumab is almost equal. And it comes in lakhs. Mepolizumab and benralizumab is coming in price of more than lakhs, but less than 2 lakhs. Yes, yes, Dr. Avadhis.
The problem with using biologicals in this part of our society, that is in Northern India, is that the cost is very high, and you have to be very choosy in prescribing any of the biologicals, because there are, as you have shown, there are only 3.7% patients who are truly require biologics.
Very right.
So it's selection of patient and cost of therapy are two major hurdles in success of biologics as well.
So it is in India it is less in use, but in foreign countries where there is price is not a matter, there they are using at, and the advantage they are taking is their frequent exacerbation of bronchial asthma is minimized. Any other? Okay.
Thank you, Dr. Ashok Singh, for elaborating on the subject.